Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vive Healthcare.
Hello, my name is Colleen Kelly. I'm professor of medicine and co-director for the Emory Center for AIDS Research in Emory University in Atlanta, Georgia. And I'm joined today on this webinar by my colleague, Josh Havens, who is a pharmacist and associate clinical professor in the College of Pharmacy at the University of Nebraska Medical Center in Omaha, Nebraska. Today, we'll be talking about maximizing success of HIV prevention and treatment, reframing drug-drug interactions in the era of long-acting injectables. So by way of introduction, in this program, we're going to discuss the following: related drug profiles for LAI agents for drug-drug interactions, dosing intervals for LAIs and potential drug-drug interactions, and finally, think about the duration of drug-drug interaction risk for patients who are on long-acting injectable formulations. So just by way of overview, we now have a few long-acting formulations that have been approved for HIV treatment and PrEP. First, for treatment, we have cabotegravir combined with rilpivirine, which is an integrase inhibitor and NRTI injectable combination that's approved for every 4-week or every 8-week dosing in people with HIV. We also have lenacapavir that's approved for highly treatment-experienced people. This is a new-in-class capsid inhibitor that's injectable, and it's injected twice yearly for HIV treatment. Next, for prevention, we have injectable cabotegravir, which, as stated, is an integrase inhibitor that is highly effective for HIV prevention when injected every 8 weeks. And finally, later this year in 2025, we're anticipating FDA review of lenacapavir when used as PrEP, injected every 6 months. So first, let's talk a little bit about long-acting injectables for treatment. So the DHHS HIV treatment guidelines are as follows. They recommend separate monthly or every 2-month gluteal IM injections of long-acting cabotegravir to replace an oral ARV regimen. So first, this is recommended in people who are already suppressed for at least 3 to 6 months on oral agents. And the current criteria in those guidelines say that patients should have good adherence and engagement with no baseline resistance to either cabotegravir or rilpivirine and no prior virologic failures. They should not have active or occult HBV infection, of course, because this regimen does not treat hepatitis B. Not currently recommended for people who are pregnant or currently planning to become pregnant. And we need to watch out for medications with significant drug-drug interactions that would be contraindicated for use with cabotegravir and rilpivirine. Of note, oral lead-in therapy with either agent is optional and can be done based on clinician-patient discussion. Quickly after approval of these agents, though, it became obvious that rilpivirine should be considered for people with viremia who are not able to adhere to oral medications for any number of reasons. And the IAS USA guidelines in 2024 did endorse using injectable agents for HIV treatment in people who are unable to take oral ART consistently despite extensive efforts in clinical support. These folks generally have a high risk of HIV disease progression with either a low CD4 count or history of AIDS-defining complications. And clearly, the virus must still maintain susceptibility to both CAB and rilpivirine if these agents are used alone in treatment of HIV infection. It's important to note that intensive follow-up and case management services to ensure that people don't miss injections and continue to receive their injections on time are very important. But I can say there is increasing experience that these injectable agents are an important tool to achieve and maintain viral suppression in people who have previously not been able to. And then to review the guidelines from DHHS about use of lenacapavir. This is recommended now for heavily treatment experienced people with multi-drug resistant HIV. And so generally this includes second regimen, ART regimen failure and beyond. Usually folks have multiple or extensive drug resistance with few treatment options. And so something like a fully active boosted PI or second generation INSTI is not available to achieve viral suppression based on resistance profiling. It's important to use past and current genotypic and phenotypic resistance testing. And new regimens should include at least 2 and preferably 3 fully active agents, including those with novel mechanisms of action. And you might consider combinations with ebolizumab, fostemsavir, or lenacapavir. If there are fewer than 3 fully active drugs, it's important to include as many fully active drugs as possible with lenacapavir, in addition to partially active drugs in your regimen. So there are some considerations when we start people on long-acting injectable therapy. And we really have to think first about the long pharmacokinetic tail that occurs with these LAIs. And that includes for both cabotegravir, rilpivirine, as well as lenacapavir. This can be months long and maybe even greater in than a year with respect to cabotegravir and lenacapavir. Sex and BMI, as well as gender, could affect half-life of these medications and may contribute to longer or even shorter half-lives in some instances. There may be a risk of drug resistance in people that are not virologically suppressed or who have delayed injections when their drugs get subtherapeutic, and viral replication could occur. There could be increased risk of virologic failure as we implement these drugs more widely in the real world outside of the clinical trial setting. And then finally, it's important that once someone discontinues, they still need ART. And so we still need to get them onto an oral regimen to keep viral suppression over the long term. So now I'm going to turn it over to Josh to discuss some important considerations for drug-drug interactions.
Yeah, thanks, Colleen. So first, before we do that, let's talk a little bit about the long-acting injectable PrEP and some of the considerations you just touched on, particularly with cabotegravir and lenacapavir, hopefully in the near future. Really, the key component is the long-acting piece that's a long pharmacokinetic tail, and that in particular presents different challenges for patients that are on PrEP. Particularly if they're missing doses. So those long PK tail of months, generally roughly a year or a little bit longer sometimes, are the key components to be considered of. The CDC guidelines for long-acting PrEP are shown here in this table. For right now, we only have cabotegravir long-acting injection available by the FDA. And the recommendations for use are those that have risk for HIV, and they have to be adolescents and above at least 35 kilograms. But the indications for cabotegravir is across all populations, which is important to note because not all of our PrEP modalities can be used in all populations. The injection schedule is you have the option of an oral lead-in up front over a month, and then you get your first injection, a second one 1 month later, and then it would be every 2 months after that time period. The injection window itself is a 7-day plus or minus from your scheduled dosing. So it'd be a 14-day injection window around that. So let's get into the characteristics of long-acting treatment and prevention for pharmacokinetics and DDI considerations. What you see here is a table that has the three long-acting injectable treatments that we're going to talk about mostly today. So in the 3 far columns here, you'll see cabotegravir, rilpivirine, and lenacapavir. Within each column, there's a sub-column for oral and then also the injectable version. And it's important to note here, really the elimination half-life, the last row that's seen there. And in the orangish yellow color, you'll see the difference in the half-lives. Generally speaking, you can say 5 times that half-life is how long it'll take for that drug to eliminate from the body. But the most important thing to think about with long-acting injectables is something called flip-flop kinetics. And really, the way these drugs are formulated is when we give the injection, the depot itself, the absorption of it is slower to release, right? And so that characteristic right there, because it's slower, the elimination half-life is longer, and we get sustained plasma concentrations for a long period of time. What you'll also notice in this table is the third row down, and it shows the metabolism characteristics for each of these medications. First, with cabotegravir, it's a UGT substrate, which means that it is metabolized through that pathway, through a glucuronidation pathway, but it does not affect other medicines. So really, we're concerned about what other concomitant medications may do to the cabotegravir concentrations if they're combined together. With rilpivirine, it's a little bit different. So it uses a CYP pathway called 3A4, common pathway for a lot of medications. And again, it's a substrate. So we're not worried about what rilpivirine is going to do to other medicines. We're worried about what concomitant medications may do to the exposure of rilpivirine. But lenacapavir is a little bit different. So it has a bidirectional nature. So we have to think about both what concomitant medications could, how those medications could impact the levels of lenacapavir, but also what lenacapavir can do to other concomitant medication levels. So with lenacapavir, it's a substrate for UGT and also 3A4. So they're minor pathways, but still a pathway. So other medicines that may inhibit or induce those pathways may lead to higher or lower concentrations of lenacapavir, depending on the characteristics of those drugs. But more importantly, lenacapavir is a 3A inhibitor, and it's a moderate inhibitor, which means that it'll slow down the metabolism of that pathway. So, for example, if we had a medication that was metabolized by 3A4 and lenacapavir is being used, you can expect higher systemic concentrations of the concomitant medication because the metabolism is slowed. So really, when we think about long-acting injectables and the DDIs specific for those, we have to think about the formulation, right? And so when we think about oral medications versus long-acting, we have to think about the differences in terms of absorption. So when we think about oral medications, they go through the GI pathway. And so anything that can disrupt absorption in that pathway can be an issue. So a lot of times we think about cation or multivitamin use, calcium use, stuff like that can bind up integrase strand transfer inhibitors. Sometimes some of these medications, particularly rilpivirine, needs an acidic environment to be absorbed well. And so we think about PPIs and histamine receptor blockers. And those medications, while in the case of PPIs, they're contraindicated, but with HR2 blockers, you can separate the doses. You want to be cognizant of that. It's different for long-acting injectables, though, because we're skipping the GI pathway and we're going straight into the systemic circulation, so to speak. And so we don't necessarily have to worry about any oral medications that would bind up the drug and cause that a problem. So what you're seeing here is the 3 medications again. And just for a review, cabotegravir is a UGT substrate. And really, we're worried about mostly any medications that are going to lower the systemic exposure of cabotegravir. So those medications would be ones that will speed up the metabolism of UGT. And notably, Reframing comes to mind. But there's several other medications that would fit into that category as well. For rilpivirine, it's a substrate of 3A. And it's contraindicated with medications that are strong inducers of 3A4. So we're thinking about lower concentrations of rilpivirine because of this induction from a concomitant medication. And really, again, rifampin is a good example of that. And the interesting thing about rifampin is it's an inducer across the board generally. And so you're going to expect lower concentrations of these medications. And then notably with rilpivirine, there's some data that suggests it might prolong the QT interval. And so any medication that may contribute to that, particularly in a long-acting setting where the concentrations may be higher, that would be something we would want to be cognizant of. And then with lenacapavir, again for summary, it's a substrate of UGT, PGP, and CYP 3A4, and it's a moderate 3A inhibitor. We're worried both about what other medications are going to do to it. So again, let's use rifampin as an example. If we combine rifampin with lenacapavir, you should expect lower systemic concentrations of lenacapavir. Alternatively, you can also think about what would lenacapavir do to other medicines. So let's think about a good example might be oxycodone. So an opiate, for example. Opiates most of them are metabolized by 3A, and they're a substrate of 3A. And if we had lenacapavir on board with an opiate, oftentimes we'll expect higher concentrations of an opiate, in this case because of lenacapavir's inhibition of 3A. So it's really important to think about whether these interactions are unidirectional or bidirectional, and how do we manage those in clinical care. So this is a table here of some of the relevant DDIs, and then on the next slide we'll talk about more specifically about lenacapavir. But again, you'll see in the far three columns, in the second column it's cabotegravir and rilpivirine combined for HIV treatment. You have long-acting cabotegravir in the third column and lenacapavir in the fourth column. And importantly, the absorption-related effects that I spoke about several slides ago here, you can see those characteristics in the top row. Really, that's most important in oral lead-in for these medications, particularly for cabotegravir and rilpivirine. But again, for long-acting injections, it's not necessarily a concern. And then what I would like to point out here, this is more for cabotegravir and rilpivirine, are the medications that are going to speed up metabolism, or what we call inducers. And so the anticonvulsants, there's several classes, right, that are common perpetrators of this. So anticonvulsants, rifamycin antibiotics, and then dexamethasone, particularly dexamethasone dose greater than 16 milligrams per day. And so what you'll find in these columns is that they're generally contraindicated, or in the case of dexamethasone, you should be cognizant of that and just be aware of any impact in systemic concentrations. And then with lenacapavir, we have to think about what classes of medications would lenacapavir keep around longer systemically. So some of those classes would be opiates that I mentioned earlier, and some of these opiates have different therapeutic windows, or be more sensitive to the effects of that inhibition. And so opiates are a good example. But you would also have medications that would be like statins and DOACs, stuff like that, and then cardiac medications that we have listed at the bottom that are antiarrhythmics. But really, the antiarrhythmic line here at the bottom is more pertinent for rilpivirine, particularly in a setting where you'd have contributory QT prolongation. And then on this side is just specific to Len. I've already pointed out a couple classes to be cognizant of, so DOACs or anticoagulants, statins, and psychotropic agents are another one that we should be aware of. All of these classes, you should expect higher concentrations of those classes because of the inhibition of lenacapavir. Importantly, some of our antiretroviral therapies, particularly some of the other non-nucleoside reverse transcriptase inhibitors, are inducers of 3A, and so we have to be aware of that. And efavirenz, etravirine, and nevirapine particularly are those that you'd want to think about. And then for hormonal therapies, generally speaking, there's not any drug interactions to be cognizant of. There's a lot of them, but some of them are metabolized either partially or moderately through 3A. And so lenacapavir could increase the systemic concentration of those medications in those settings. So probably the most important thing is how long should we be aware of this DDI potential, particularly with lenacapavir, because it can impact other medications. And so again, it's a moderate 3A inhibitor, and so we should expect higher concentrations of other medicines, concomitant medications. So we're really worried about potential toxicity from those medicines. But because lenacapavir has a long half-life, we should really be worried about that even 9 months after the last dose, probably even up to maybe a year. but the package insert would state 9 months. And so that would mean in a setting where somebody received a dose of lenacapavir before, but then received a drug that may have a drug interaction potential, say oxycodone, for example, you may have higher levels of oxycodone because of that, even though they haven't received a lenacapavir dose in a long time. And then most importantly, a lot of the current DDI studies that we have available are mostly done on the oral versions of these medications. And so we're really limited in data for long-acting drugs with pharmacokinetic DDI trials. Some of the clinical challenges that arise from long-acting injectables, particularly for PrEP and for treatment, are really around this long pharmacokinetic tail. And the difference in pharmacokinetics really leads to considerations for not only DDIs, but resistance. If somebody were to miss a dose, for example, in HIV treatment, or if somebody on PrEP maybe had an HIV exposure after discontinuing long-acting PrEP, that would be a consideration in a setting of seroconversion. And again, as the HIV epidemic, as people get older with HIV, we have to consider what are the aging perspectives that we need to take into consideration for the pharmacokinetics of these medications. And really, that's not well understood. But generally speaking, these medications are not metabolized through the kidneys, and so you don't necessarily have to worry about renal function, although we don't really know the full impact of that. And comorbidity certainly could have, we still relatively understudied with these long-acting injections. And particularly if you're using lenacapavir, we need to be cognizant of polypharmacy. So folks that have a lot of medications on board, because we don't necessarily want all these bidirectional DDIs to be an issue to manage. So what you're seeing here is the Liverpool tool, and what we've done is this is cabotegravir and rilpivirine DDI profile based on that Liverpool tool. Really, we just wanted to give a pictorial view of proportionally how many drugs are permitted for use, how many should there be a cautionary, how many are prohibited. You'll see in the yellow, orange, and red, those are the ones that are either cautionary or prohibited for use, and that's roughly 20%ish. So those are the ones you'd want to be cognizant. And really, what we're worried about is medications that are going to impact the concentrations of cabotegravir and rilpivirine. But importantly, we just need to note that most medications are permitted for use with long-acting cabotegravir and rilpivirine. Alternatively, we have lenacapavir's DDI profile, again from Liverpool. And oftentimes when patients are heavily treatment experienced, they may have other medications on board, so we need to be cognizant of what the effects of DDIs might be from lenacapavir. So because lenacapavir is a 3A inhibitor as well, you'll see that the permitted use of other drugs is less than what we just saw for cabotegravir and rilpivirine at 65%. And really, that's because lenacapavir might increase the toxicity potential for other medications through 3A inhibition. So I'm going to turn it back over to Colleen here to address any issues with DDIs in primary care.
Yeah, so I think, the first step in managing DDIs in primary care is really just to have a heightened awareness. Management is doable. It's usually easily managed once you recognize a DDI. The problem becomes when you don't recognize that you have a DDI. So the first step is to just check, is to just be aware when you're adding a new drug to someone who's on ART, or if you're adding ART to someone who's on other medications, the safest thing is just to check for those DDIs. So look into the DDIs when starting new medications and just double check yourself. In most cases, it's easy to manage that DDI by an alternative medication, by some heightened monitoring or other methodology, just to ensure that there's no adverse outcomes for the patient. So I also want to mention, I'm a clinician, an MD, and Josh is a clinician as well, but a pharmacist. But I think it really highlights how managing DDIs is an interprofessional team. So both physicians and pharmacists often collaborate together to manage DDIs. We can't all be expected to be experts on every possible factor that could contribute to DDI. And so I think working together is really the best approach for the safety of the patient. So there are a couple key resources that are really important to manage DDI. So there's the for HIV antiretrovirals, the DHHS drug interaction tables are very comprehensive and very helpful to identify drug-drug interactions for people on ART. Even quicker is the Liverpool HIV drug interaction checker that's available online or as a phone app. That allows you to just input the drugs that you're looking at and let you know about potential interactions. I use both of these tools regularly to make sure that I'm not looking at a potential drug-drug interaction when I'm adding or changing medications for people on ART. So that about wraps it up for our session today. And so to take you home with some concluding points. So once again, drug-drug interactions can occur with long-acting injectables, but they are definitely manageable if they're recognized. DDI interactions with CAB and rilpivirine are unidirectional. So what that means is we're more worried about what the other drug will do to the CAB and rilpivirine levels. So we're worried about the impact of other medications on CAB and rilpivirine. In contrast, the DDI interactions with lenacapavir are bidirectional. We're worried both about what the other medication can do to lenacapavir levels, and we're worried about what lenacapavir can do to the levels of other medications as well. So that's an important distinction between these medications, and something that I've learned a lot about today too. DDI impacts with long-acting injectables can be challenging because of the long half-life. So if you're not aware that your patient recently received one of these long-acting injectables and gets a new medication, you could be dealing with some unexpected adverse outcomes of the drug-drug interactions. These medications last a long time. That's what they're meant to do. And we're looking at remaining in the body up till 9 or 12 months or even more, especially for cabotegravir and lenacapavir. And so it's important to not forget about the potential for DDI, even if someone has come off of these long-acting injectables in the last year. And so thank you so much for participating in this event today. We appreciate your time and hope you learned a lot about drug-drug interactions in long-acting injectables.